As soon as you mentioned my name, of course, my dog needs to be in the screen. But slides and move them out of my dog's way. Okay. So good morning, everyone. I'm Samantha Hill. I am part of the team here at UAB. And today I'm actually joined with two other people that are on this call, Lynn Matthews and Leticia Lopre. And we're going to be sharing a little bit of pieces of our work as a way to kind of talk about some of the strategies and considerations that are necessary when using implementation science, either in clinical spaces or to advance clinical services. And so the objectives are really, again, to do what I just said. Each of us has a different project that we'll discuss, and they're in various stages. And so hopefully that'll be helpful to you all. I've reviewed a lot of the different projects that are within our hub this year. And so I think hopefully this will actually be able to start a little discussion that I've left time for at the end to help with brainstorming and working together collaboratively to maybe overcome some of the barriers and challenges or things that have worked well as you are working on your implementation projects. And so I'll start with mine, just to give you a little background. So my background is I'm a pediatrician and I'm an adolescent medicine specialist within that. I actually am in the pre-phases of trying to plan an implementation science project surrounding injectable PrEP specifically. And it's within the Adolescent Health Center. And so I have this slide because it's really important to kind of understand the setting in my work in order to kind of have some context for what I'm about to talk about. And so within my field, I actually work in two distinct clinics that are located in the same place, but are run by two organizations. The injectable PrEP that I'll be talking about, the project that I hope to be able to do, will actually be done within the General Adolescent Clinic. And that clinic is actually a clinic that's affiliated with our children's hospital here. And so it's right next to UAB and all those things, but it's literally an entirely separate entity from UAB. It is funded entirely from patient revenue as far as the services that we provide. And then we do have interdisciplinary clinics or days within our clinic. However, those additional disciplines are actually usually staffed with trainees, usually maybe one faculty and then multiple trainees. And within this clinic setting, we actually have a broad focus. So it's not just on sexual and reproductive health, it's on eating disorders, mental disorders, anything you can think of relating to teen health. And we actually really don't have a formal research infrastructure. So each individual provider or faculty member, regardless of the discipline, may or may not have a research focus. And so there's usually a variety of things going on at the same time, all in an effort to improve clinical service. Obviously, my focus is on HIV and HIV prevention, and currently in this setting, injectable PrEP. I contrast that with the other clinic that I work at. It's actually in the same place, but it's actually a UAB clinic. And it is actually funded by HRSA, so it's a Ryan White clinic. And it also is interdisciplinary, but it actually has interdisciplinary staff who have finished their training and are full professionals.
Yeah.
Can you hear me?
More green fire?
The HIV clinic focuses specifically on being an HIV subspecialty clinic. And then it does also have research infrastructure within it. And so as I am sitting here planning my injectable PrEP implementation project for the future for the General Adolescent Clinic, it's important that I'm able to kind of compare and contrast. Oh, I'm sorry, y'all, my dog is acting up. Compare and contrast the different resources that I have access to in each clinic and what resources can be shared and what can't. Additional little background, this data is a little old right now, but one of the reasons I am focusing on adding injectable PrEP to the other PrEP options that we have in clinic is because we do have a decent HIV incidence among our young General Adolescent Clinic. And the General Adolescent Clinic serves individuals 11 to 21. You can kind of see the numbers right there based on age as well as gender and a little bit of ethnicity. And then the other reason it's important is maybe 4 or 5 years ago, I actually did a very small chart review study on our clinic and found that within people that are presenting just for routine primary care and prevention care, that almost half of them had an indication for PrEP. And this is a mixed sample, guys, girls from all over, but none of them had actually been recommended PrEP. Since that time, we've been doing much better at least discussing PrEP and offering PrEP to individuals, but the injectable PrEP kind of poses an entirely new dilemma. And so within the implementation science framework, some of this will actually be built into my project, but I'm actually fortunate enough to have had several projects that actually will lend themselves to providing some initial context to a study. And so as you can see, I used some of the determinants from the CFAR framework, which is what's on the left-hand side of the screen. And then what I did on the right-hand side of the screen is I went and actually tried to identify what information I already have from previous studies pertaining to what I may need to take into account using injectable PrEP. And here is where there are some dilemmas and things that, or not dilemmas, but things that I need to consider. And so for instance, if you're looking at what the intervention specifically characteristics should entail, you know, the reason I know injectable PrEP is a hot button topic, but one of the reasons I thought it was important to actually work on trying to implement this is because our clients are really actually asking them for it. Many of my clients within the general adolescent clinic are not so much interested in anything in the pill form. And so we're gonna see what we can do. In addition, all the clients like the options of like the idea of actually having options. So whether that's between generic and brand name, or the two brand names that are available, and the oral versus injectable. So they like just even having the options and knowing about the options. What I also realized is one of the barriers to PrEP uptake in general within my population is just the lack of their exposure to a comprehensive sexual education. And so a lot of the times when we are introducing PrEP within clinic, we found in different studies that this is kind of the barrier that we have to overtake first. And so in whatever implementation or strategy that I come up with or my team comes up with, we really have to make sure that we deal with this particular important aspect in addition to the HIV education. And then finally, many of the clients that we serve and participants that have been in research studies have really indicated the need to have someone help support them on PrEP, whether that's a peer, an adult, coach, mentor, things like that. When I'm looking at some of the other things as far as the providers, what they've realized that they need based on prior work is they really want real-time, up-to-date information about PrEP. And they don't necessarily have a great way to do it. And part of the reason is, again, some of them, their subspecialty is eating disorders. Some of them, their subspecialty is mental health disorder, but they all do at least one general adolescent clinic. And therefore they all have recognized the need of actually knowing about PrEP and being able to prescribe it in real time to their clients that come in. They also have continually shown within different studies and different interviews that they need assistance in how to actually start PrEP, not so much manage, but start PrEP and make sure that their patients are successful on PrEP, including when things like prior authorizations are needed and things like that. And so again, this clinic doesn't have a social worker that's a paid staff member. That we have social work trainees that come on specific days, so they're not always available. And so they may not always be able to help us in real time with the PA. And in a busy clinic, it might be challenging to actually get a PA going and done in clinic. And then, as with any clinic, there's so many topics to cover. And so figuring out how to actually work with the clinic flow and efficiency to make sure that there's actually time to have a full discussion about PrEP, as opposed to like, hey, this is PrEP, you should use it, or this is what it does, is something that providers have identified. From a clinic standpoint, some of the things that I've done with either clinic managers or nursing or additional interdisciplinary staff has really talked about the need for an efficient clinic flow. Their biggest concern is that this is yet another thing that we're adding, and it's more complicated than how PrEP has been in the past or up to date. And they're really concerned that this will slow clinic down farther. they've also said specifically, if we're going to do this, there needs to actually be a on-staff social worker in every clinic and not just in some clinics, as well as a PrEP navigator within every clinic and not just some clinics. And again, every clinic means Monday through Friday, morning and AM clinic, having someone present. And then the other thing that's been a big concern, I put it under clinic, but it's really been a concern among the clients, the providers, and additional staff and team members, is really having a way to actually do confidential STI testing for our young people that happen to be receiving insurance through private payers, and who may or may not have parents that understand their desire to get STI testing, let alone beyond something like PrEP. And so figuring out how to get that done efficiently. And so what I'll do, I'm just going to summarize the unique challenges I found specific to my particular space that I work in before I transition over to the other two presenters, and hopefully we can have time to discuss some strategies about these at the end. And there's a comment in the chat and I cannot move my mouse fast enough to see it. Can someone read that comment in the chat for me if it's pertinent?
It says, it's from Greg Rebchuk at UCSF, says, I was in a meeting yesterday with an organization in Oakland. They said they're hearing a lot about PrEP stigma being a major barrier for young 14 to 26-year-old African-American MSM getting on PrEP. Are you hearing that from your adolescent population too?
Yes, so I'm hearing that not only from African-American MSM, I'm hearing that from African-American women, I'm hearing that from non-African-American populations where I am. And they acknowledge that the stigma, they recognize that there's a stigma about PrEP and HIV, particularly within LGBTQ communities, at least my population. And they say it wouldn't be a big deal if they had actually known about PrEP earlier. And we know PrEP has been around for a while, but the populations that I work with at least have just started learning about PrEP, probably within the last maybe 2 years. And so they feel like PrEP is too new. And so in addition to battling or trying to overcome the need for comprehensive sex education, HIV education, what makes you at risk for HIV, they feel like the medicine is too new. I hope that answers your question. And so some of the unique challenges specific to my clinic, again, is because it's a clinical setting, it's really trying to figure out a way to implement this service so that it's long lasting and doesn't end once whatever grant I'm going to claim is coming ends. In addition, with the other providers, it's really how do you work on maintaining their interest and confidence in actually being able to prescribe PrEP in real time. For those of you that may not know me, and for those that do know me, oftentimes I'm just on call for my colleagues in clinic, which is fine, to help troubleshoot their PrEP challenges. And so it's fine with me, but as you can imagine, that's not the best and most sustainable method for doing anything for PrEP, let alone something as complicated as injectable PrEP. And then again, because this particular clinic is actually a Children's of Alabama clinic instead of a UAB clinic, there are actually some different rules and regulations as far as what the hospital allows. And so simple things like having a private fund set up for everybody to get their STI testing done is actually not so simple within the children's organization. And so trying to troubleshoot and find creative ways to have that so that there's parity in services. And so it doesn't matter if you're a publicly insured versus privately insured. In addition, creatively funding interdisciplinary teams. So again, in the general clinic that I work in, the interdisciplinary staff, they're all trainees with the exception of 2 faculty, whereas in the HIV clinic I work in, that is research funded, we have the fully staffed professionals. And so how do we get fully staffed professionals in the general clinic? And then finding ways to do all this, that is, as always, my theme is developmentally appropriate and finding educational resources that are such. And so those are some of the unique challenges that I face in my particular implementation science project, looking at injectable PrEP. And then, so we're gonna switch to, I think first up is Letitia Lopre, who also here is here at UAB, and is going to be sharing a little bit about her particular project that deals with a statewide PrEP care cascade. And I'll turn it over to Letitia.
Thanks, Sam. So I'm presenting something that I actually presented at the National Minority AIDS Summit. So I presented it for NMAC, and ultimately it was to just discuss a project that is supposed to be really working with multiple community members across the state of Alabama to understand how we can improve our PrEP care cascade among the clients we serve. Could you advance the slide, Samantha? Okay, I advance the slide. Okay, those are my disclosures. Next slide. Oh, these are slow transitions. I'm sorry. Okay, so right now, as Sam already kind of outlined, in our state, we have about 11,000 people that the CDC predicts likely has an indication for PrEP, and probably more that would just enjoy and benefit being on a tool that we know is and is supposed to be sex positive and help with having guilt-free, positive sexual experiences. Ultimately, we have a group that's already established in our state called the Alabama Quality Management Group, which is a consortium of several Ryan White clinics who initially were providing HIV care and were mandated by HRSA to track HIV care outcomes. Most of these facilities, community-based organizations, or FQHCs now also are offering PrEP, or they're offering STI and HIV screening. So at these meetings that we have quarterly, it was suggested that we start tracking how many people we had on PrEP care. And with that, is it possible for us to actually look at PrEP care outcomes? And this was several years ago when we first started talking about this. So this kind of prompted the overall goal for this study, which was to basically try to create something that would help us within that group track our outcomes related to PrEP care, which is not as easily tracked as we have for HIV care, because we don't have the same mandates for tracking and reimbursement attached to it. Next slide. So overall, I use implementation mapping for the overall study structure for this like kind of pre-implementation work. We started with a needs assessment, just finding out, hey, what current data are you collecting related to PrEP care continuum? And this is for anyone that's doing STI and HIV testing. We did interviews with all of the people who are willing at Alabama Quality Management Group. And then we did surveys asking them, can you tell us who you're currently offering PrEP care for? Then we met with selected few who said that they would be willing to share data. So it was 9 of the organizations within AQMG. And we talked about identifying implementation strategies, what were our overall goals in regards to defining the PrEP care continuum. We put this into a logic model. And right now we're working on strategies to support what was identified as the major implementation strategy to track the PrEP care continuum. And that was a data dashboard. Next slide. So this is the Alabama Quality Management Group. This is pre-COVID picture. Now all these people have on masks, or maybe they're maskless as the rates improve. But this is the group that we all work in front of our building. This is Bochelle. Next slide. So a little bit about the Alabama Quality Management Group. They have a mission statement. And I think the most important part that I've taken away from working with each one of these individuals is that they are passionate and driven about the care that they provide. And a lot of times for UAB, we are a major institution that has major funding attached to that. A lot of these organizations are serving our Black Belt region. They do not have the institutional ties, the political ties, and the funding structure that we have to support patient care. So I really look up to them and the work that they do, because they're really the boots on the ground that I think are serving the rural epidemic, which is what we are identified for in EHE. Next slide. This is their vision statement. We envision optimal health for everyone living with HIV/AIDS, supported by a healthcare system that assures ready access to comprehensive, competent, quality care that transforms lives and communities. Next slide. So AQMG was founded in 2006. It is consisting of people who have Ryan White funding Part C and D, and it has Huntsville, Alabama to Mobile, Alabama. And what I want to point out is that in our state, 67 counties are primarily receiving services from groups within the AQMG. So the reach for these organizations is vast, and I think the potential is vast as well. Next slide. These are some of the goals of AQMG, and all of it's around quality improvement. And again, tied to HRSA and tied to HRSA funding. So these conversations that we were having around PrEP really hadn't happened before because at that time they weren't mandated. Next slide. This is the service area I want to show. And I actually love this graph because it does show very nicely the reach that the AQMG organizations have. And you can see with this that number one, there have the main clinics present by the stars, but that there is one organization, MAO, and a few others that have satellite clinics where they offer telehealth. And that's where you're going to see really our Black Belt being reached primarily with organizations like MAO and Selma Air, providing services in the areas that I don't know if any of you have had the chance to come and visit the Black Belt, but are significantly under-resourced. And I think a lot of people would be surprised at the amount of poverty present within these locales. Next slide. This is a famous initiative that they've already started called Data for Care. We can go through because I don't want to take up too much time. Next slide. Okay, so this is our PrEP care continuum. So this is a part of the needs assessment that we did. We had a 92% response rate, and really I was excited because we were able to, number one, capture of the 11,840 individuals that CDC predicts that we have within our state that have a PrEP indication. We've screened about 6,481 within our groups. And then you see this huge drop off where it comes to linkage to PrEP care, prescribed PrEP, and retained in PrEP care. So out of the 9 organizations we were able to survey, and you saw the reach across those organizations, only 395 people at that time were actually retained in PrEP care, and only 478 have received PrEP prescriptions. So I presented this back to the group, and this was kind of one of the, I think, launchers for this study, showing that we weren't really having the reach with PrEP that we needed. Next slide. So we did key informant interviews. We did 12 semi-structured interviews as a part of that needs assessment, and we did it with multiple people in each one of the groups. So we talked to providers like Samantha Hill, we talked to data managers, we talked to senior leadership within the clinics, and we really wanted to understand how can we all share data so that we can in real time be able to address some of these barriers we're seeing, some of these gaps that potentially could perpetuate disparities that we already see in regards to HIV rates. And with these interviews, the biggest things that came out is they said, look, we want to be able to, number one, look at social determinants of health that are likely to predict better than CDC guidelines whether someone may be vulnerable to a diagnosis with HIV in the future. So things like intimate partner violence, food insecurity, looking at neighborhood level factors. They wanted to have this captured and shared in real time because they said that they felt like they sent their data off into a space in the clouds and they never had access to that data. And with that, we said, okay, this was, gosh, my mind always focuses around COVID, but this is before dashboards became so popular with COVID. And we said, okay, we want to do a data dashboard, and we're going to have a system where we can all share our data. We can share it going across the PrEP care continuum, and we're going to put it and display it in a dashboard so you can manipulate it based off these variables that we've identified are key for us to understand where gaps are in the PrEP care continuum. Next slide. So that was our main implementation strategy for this project within the mapping paradigm that we created. So I talked about the needs assessment that we did. We put this into our logic model. For program outcomes, we decided that we really needed to, number one, access and work with the state health department and DIS, because they are the boots on the ground that do the screening and capture people who are testing positive for STI. So we want the data share with them. We need to have a uniform, systematic way of capturing data and uploading it. And this dashboard need to be acceptable and feasible based off of workflows that were already present in people who are, underpaid and overtaxed and doing 100 jobs already in that day. We wanted that design strategies to help with not only the data uploads and data management, but use of the dashboard. So that's what we're working on right now, is designing these strategies, and then create protocols and have materials present that would help with use of the dashboard as well. I will highlight in this process, this all sounds good while I'm talking about it, but as I said, these are all vastly different organizations. So one of the biggest barriers that we had when we were going through trying to outline really these protocols and looking at how we're going to all share data is we don't all collect the same data. we don't all have electronic medical records. A lot of us are doing things on paper in the field. So the needs were different for each one of the organizations. The data that each organization was currently capturing was vastly different because again, it wasn't always connected to a funding source, a reportable mandate based off funding, and experience with data management and data entry varied vastly across the different groups. Next slide. And this is just showing you the partners and the reach that we have with the partners who signed it up to do the data dashboard. So I'm excited because it's, again, potentially a large reach in what we'd be able to cover and look at in regards to the prep care continuum. Next slide. So after several meetings, and it was probably, I want to say 6 or 7 meetings where we went through really, number one, things like data variables that we all wanted to capture, resources that each organization had, people on site that they had to capture this data, and what metrics for the prep care continuum we thought were important for us to be able to intervene on. This is what we came up with. And this is still evolving, which I think is the beauty of implementation science, is that, you know, right now we're in the process of piloting our first data capture where we're tracking race, ethnicity, housing, STI diagnosis, insurance status, whether they tested for HIV at your organization, the zip code of the client, whether they're employed, and then we looked at sexual quote unquote risk factors based off CDC guidelines. And I will tell you, based off this first data capture that we did, the data has varied, the data quality has varied, and the training that we need to do and the strategies to support this, this program we're trying to create are likely going to vary based off of the experiences that the groups have at each one of these sites. So we're in the process now. We've done this first data upload. We are building the dashboard, and we're going to actually show the dashboard to all of our partners, give them time to play and access the dashboard, and have them all come back again for another meeting where we assess feasibility and acceptability of that dashboard. And not only the dashboard, but the steps along the way. So capturing the data upload and entry, and manipulating the dashboard on our website that we've created. Next slide. So I think that covers, for me, the major barriers that I've faced in regards to this implementation project. And I think the nice aspect of implementation mapping, because it truly engages community partners. I think that they feel, at least I hope they do, that they've had a role and their voices have been heard in this process. And it also identifies major gaps and differences that you need to address in regards to creation of strategies to support whatever intervention or evidence-based practice you're trying to implement. I have multiple individuals who've worked on me with this project. So I want to thank Dr. Brangavero, Adia Rana, Jitesh Palmer, Ashley Tarrant, and then Dr. Thomas Kreger, who helped me understand what implementation mapping really is. And then all of the Alabama Quality Management Group members and people at 1917 Clinic and at SAM in the Adolescent Clinic, because they were our UAB representatives for this study, which was fantastic and kind of led the way because they have sometimes more experience with data capture and may still be under-resourced. And then UAB CFAR, who supported this initiative, and then of course, Alabama Department of Public Health. So that is my presentation, and I can shift back over, I guess, to Lynn, who's next.
Yeah, and we'll go to Lynn next. And I want to highlight, in case you didn't catch it, so Letitia and team are really not only looking at the state with different settings and resources, they're one of the few projects that does include teens, which has, I know, messed up y'all's data capture because we obviously aren't asking for income when teens come into visits, and then they're coming in for like general visits. So it's just very different. So the barriers that she's talking about implementing such a vast study throughout so many different settings is actually quite impressive that they've been able to get something, I think, useful is what it sounds like.
We hope.
So our next, oh, there's Letitia's contact. Our next presenter, oh, so many slides, is going to be Lynn Matthews, and she is also here at UAB, and is, I believe, going to be talking about, oh, perfect, her project with PrepPro.
Sorry, my unmute button was hiding. Great. Well, thanks everyone. Samantha is someone who I mentor a lot. And so Samantha asked me to give this presentation and I, of course, had to say yes. And I hope that I caught the memo, but the idea of talking specifically about clinical strategies related to implementation science was a little bit tricky for me because I am a clinician and I am new to implementation science. I've kind of gotten here probably the way a lot of us have through these CFAR EHE efforts. And so I don't really know a way to think about implementation science that isn't about clinical strategies, but I tried to highlight, what I think might be relevant from a project that we're just starting. So I'm going to talk about this project called Prep Pro, which is training family medicine providers to promote PrEP prescription for adolescent girls and young women in Alabama. And I wanted to start with the team. So you've already met Dr. Lopre. We are MPIs on this project, and Samantha and Robin, Tina Simpson, who's another adolescent provider here and researcher, is part of this. Shay Isihunwa is a postdoc working with me on this project. And then I think important just for an early, consideration of what might be different about a clinical project. Nick Van Wagner is a clinician educator who joined this team because of our desire to train family medicine providers. And then Brooke Hubner is a PhD whose expertise is in medical education for adult physician learners. So Brooke joined our team to help us with that. And then Dustin is a biostatistician, and Doug Krakauer and Meredith Clement are consultants helping with some specific pieces of our intervention that are things they have worked on in the past. And this is informed by the R34 proposal, is very much informed by some work we did with one of our EHE supplements, which we call A4 PrEP, because it was about access to PrEP for adolescent girls and young women in Alabama, which somewhere along the line that comes out to 4 A's. So we called this the A4 PrEP study, and we conducted provider interviews first with providers around the state who take care of Black adolescent girls and young women. And we were only able to conduct 11 interviews. It was tricky. We launched this right as everything was shutting down with COVID. But we had really rich data because the providers who participated were pretty keen to talk about this topic with us. And so what we found were that some of the reasons for quite limited PrEP prescriptions to this population in Alabama were a lot of stigmas relating to HIV, but also just sexuality, and not even, gender minority sexuality, but girls having sex with men was something that providers were not super comfortable talking about. And that when we get to the client data, I'll talk about that the girls were also therefore not comfortable talking about. And then we also found that providers had a lot of limitations to their PrEP knowledge and comfort with the guidelines about PrEP for younger populations. And then we learned a lot about the healthcare systems and structural barriers that impede PrEP access, like insurance coverage or complete lack of any sexual health education in the Alabama public school system as mandated by the legislature. And this is something that Samantha presented at the EHE meeting, and it's a manuscript that is desperately awaiting people to agree to review it. So if any of you have been asked to review it, please review it. Put a little pitch out there. Then we also conducted client interviews with girls and young women in Alabama who had an indication for PrEP, most of them based on sexual activity. And again, we had a harder time recruiting than I would have expected, but we did get quite rich interviews. And the interviews with the clients also confirmed there's a lot of stigma and stereotyping around them being sexually active, which makes it hard for them to talk about it with providers who don't start the conversation because the providers aren't comfortable. There are inadequate discussions about sexual health in all of the systems that they work or live in. They do get a lot of information about sexual health from other sources, which we saw as an opportunity. And we learned that, or heard from the girls, that they have really learned to advocate for themselves in healthcare settings. They were very empowered they told a lot of stories about how they had kind of overcome a lot of barriers to access contraceptive care. No, they didn't really know about PrEP, but they knew a lot about contraceptive care and talked a lot about overcoming barriers to access that, as well as STI testing. And they don't know, as Samantha already said in response to that earlier question, this population really doesn't know that PrEP is an option for them. It's something that they see marketed to MSM populations, and so they don't see it as an option. But once they hear about it, they're like, well, maybe that could be good. And then Madeline Pratt, who's a project manager who works with me, presented this at the CFAR HIV and Women Symposium. And this is also under review, waiting for someone to agree to review it. So based on that formative work and a lot of other work in the literature, we designed or proposed an R34 to develop a training program for family medicine residents in Alabama. I don't have a slide on why we chose that population, but most rural healthcare in this country is delivered by family medicine providers. And there's a lot of family medicine training programs in our state. So there was an opportunity to work with programs across the state. And we thought if we could figure out a way to train that group, that would be something that would then easily be applied to other more specific provider types like pediatricians and internists. But we thought starting with family medicine providers would give us a broad reach. And so we are using the CFAR, and the intervention components that we are offering is training in PrEP and HIV epidemiology, working with providers on taking a sexual history, talking about sex and sexuality. And then we are also developing a PrEP champion program. So like Samantha alluded to, even in the academic medical center where she works, where people have more experience with PrEP than a lot of the community settings, it's really helpful to have someone kind of on call who can help answer questions when someone is ready to offer PrEP. And I guess one of the things I wanted to highlight in thinking about kind of clinical interventions is that, we have these little pink circles with H is where we were involving the healthcare providers in our research. And so they're part of kind of each step of the way in order for us to design something that we hope will work and be scalable. So our steps in the first aim were adapting that content using a community advisory board that includes family medicine providers, as well as we decided clinic administrators who have a lot to do with kind of how these things get billed and how visits get scheduled. And we're doing intervention mapping with that group. And then we'll do some focus groups to get specific feedback on our draft tools and content. And then we'll test our intervention with 10 family medicine residents and 2 PrEP champions, get some feedback on that, then do it again and have an open pilot. And it'll be pretty small. It's an R34, so we're mostly interested in acceptability and feasibility. But we also will look at clinic level data to figure out, did we make an impact on the proportion of girls and young women seen in the clinic during the time period who were prescribed PrEP or tested for HIV or tested for STIs. And then we'll also do some in-depth interviews with women or girls and young women who participated in the program, as well as the providers. And again, just thinking about kind of a clinic level intervention, if you look at the little pink circles, again, the providers are part of each step. The providers are part of our scientific group. They're part of our community advisory board. And then of course, they're participating in the research and then participating therefore in the feedback on our pilot program. So our draft components, we have a PrEP education curriculum, we have a curriculum on taking a sexual history, and then we have this idea of PrEP champions. And so we kind of have original content that we're starting with and then anticipated adaptations. I'm going to break this table up into something a little bit easier to look at on a slide, but I just wanted to show you this to start with, that if we look at our anticipated adaptations and what we're doing, the PrEP education will be adapted to focus on Black adolescent girls and young women. Now, a trick with us, and this is maybe beyond the scope of this presentation, but the provider population we're working with really has limited experience with PrEP at all. So we are particularly interested in this gap in PrEP prescription to Black adolescent girls and young women, but we also need to train the providers to provide PrEP to everyone that might need it. So that's a balance that we are trying to strike here. In terms of sexual history taking, we need to address the fact that there's a lot of stigma toward discussing sexuality in the clinics here, and some of the needs of the specific populations. And we're hoping the girls and young women on our community advisory board will help us there, as well as the providers. And then in terms of the PrEP champions, what we're trying to adapt this to is to have the family medicine residents identify people who are sort of leaders and self-identify those who are most interested in PrEP and PrEP content, and they'll serve sort of as peer mentors. And then the other components, we want this to be scalable. So we're working with our educational team on, what can we do to make this training that will kind of be retained by those who do the training, but also be something we can disseminate. So we're making everything Project eco-friendly, which is kind of a collaborative model of medical education, where video conferencing can be used to train people across many, many sites. So we're working on that. We're doing a lot of case-based learning. And then I already mentioned the PrEP champions as on-call support. And then retention strategies. This comes back to the fact that we have some kind of professional medical educators on our team, and thinking about how we provide information quickly and efficiently, because the family medicine residents don't have time to have like 6 sessions on this. They have time for maybe 2 noon conferences. So how do we have some kind of reminders and tools available to help them retain what they learn? Is that kind of like a pocket card, or is that an app, or is that reminders in their EMR? And that's one of the questions that we'll be kind of throwing to our community advisory board that includes these residents to think about what works best. I think that's it for me.
Thank you, Len. And your project is extremely intricate in the fact that you're starting something from scratch, or starting a service from scratch with providers and clinic settings that are different than your own, because you're in the ID world. And so I imagine—
Oh yeah, that too.
I imagine your clinic rolls a little differently. And so what I wanted to do now, because I know this was really heavy on PrEP, and I apologize if your project isn't looking at PrEP, but I wanted to open up and provide space for people to maybe share some of the successful things or some of the barriers that they've had with their own projects, where maybe we can all help and try to identify possible solutions to try to overcome those. I know everybody's project's a little different, but if it's something that's setting based, or how do you get clinic buy-in? I know my project and Lynn's project both deal with clinic buy-in from various stages of who has oversight of that clinic. But I just wanted to open up the space, and I have questions prepared in case people don't want to share. Okay, so I will ask a question then, maybe I can get—
sorry.
Go for it, go for it.
Okay. Hi, this is Marjorie Gondre Lewis. Thank you so much for those presentations. It's actually opportune, we just had a meeting, our first meeting with the clinic sites for her project. And, the pushback was palpable, and what you mentioned at the beginning about, interrupting, clinical workflow was a huge concern for many of the sites. And, people, there's a lot that needs to be involved in kind of building those champions. And the amount of talking, after that meeting, I felt like, oh my goodness, I'm gonna have to go on the road, so to speak. I'm becoming a salesman, to the clinicians, because you do need to build those champions, and people are uncomfortable. People are stretched. They're talking about their visits being 20 minutes, and to add anything more would be 10 or 15 minutes. Susan, that's the pushback, right? So Susan is asking, what was the pushback about? You know, that adding more time to the interface between the physician and the patient, or even any medical staff. You know, they had problems with any medical staff because it just would introduce such a hardship for them, you know? And then of course there is the problem of funding as well. And so recognizing the idea that there is some kind of this, well, I wouldn't call it disruption. From my perspective, it's adjustment, right? Like if you need to take blood samples for people to determine whether they have diabetes, or you take their blood pressure, you know, as a matter of course, you don't think of that as an inconvenience. It's just part of what you do, you know? And so what are some suggestions? I know all of you kind of addressed that this is ongoing everywhere, and I was kind of heartened to hear that. But how do you address that? How do you infiltrate that culture or that mindset within the clinical setting? What would you suggest?
I can start. I'll say in my setting, there's me as an individual provider who is willing to do it. But then I also have buy-in from our division director, as well as the clinic manager who oversees many clinics in addition to ours. And so really having conversations with the two of them about the importance of actually offering this service to be in alignment with the recommendations and the guidelines from our governing agencies has really helped both of them. They were both on board in general, but it has helped remind them why, you know, when we have a division meeting as a whole or a clinic meeting as a whole, why space needs to be carved out to have these discussions and to not only have them in those settings, but actually include them in our QI meetings as well, so that we could really talk through and allow people's voices to be heard as far as what their concerns are, like you're saying, and find ways to adjust. Because I like your word about adjustment, because that's really what it is. But that's what's worked best for me, at least so far.
Thank you. And I know somebody else wanted to respond, but I just want to be clear that our project is not about PrEP, and it's not about talking about sex. The project is about mental health screening and introducing that as part of what they do for people with HIV, right? And so it's an unspoken about problem that's there that decreases quality of life and can potentially increase adherence to their medications if their problems are addressed. And so just for context.
I can say that sometimes being able to show data and outcomes and showing and explaining, I mean, not explaining, but discussing value added to get buy-in can help. And then trying to, again, like focus on the strategies that you could implement that wouldn't, not using the word disrupt, but cause a huge adjustment in their workflow. So if there's a way that they can do mental health screeners that is incorporated where the patients do it in the waiting room, or, you know, like focusing on that aspect of it, how can we make this easier for you to integrate into what you're already doing on a daily basis and acknowledging the time that people are already spending trying to hit all these benchmarks in regards to care. So that might be a strategy.
Mm-hmm.
Yes, Susan.
Hi, a problem we're having is the extent to which organizations have all their services siloed, and so they don't talk to each other. And so, you know, we're trying to get them to do some PrEP activities. But so as an example, you know, there's the clinicians are seeing young gay men about PrEP, but so far they haven't been promoting the activities that are about PrEP. And, that's just one example. And we did have a meeting this week or last week that my time is crazy. That was really great. We got everyone in on a Zoom call, and they were all talking about it. But it really takes quite an effort to get everyone on a phone call. So I'm just wondering if people have come up with other strategies about reaching between siloed activities.
Greg,
I could just maybe jump in with one, because the project involves not like the C-suite, which has sort of changed when organizations have gotten subsumed by larger healthcare networks, and then the communication staff, the finance teams, the social media people, and the education folks and the outreach team. So it's like trying to get everybody aligned has really been a problem because of these silos.
Yeah, the silo, because we have that in our clinic as well, given that each of us has our own subspecialty, I suppose is what you would call it. What has worked on a smaller scale in like a one clinic setting is really having accessible things. I think like Lynn had hinted that, to really keep that retention of the information that they held, because getting them together to do a quarterly, hey, remember, in my case, remember, this is what prep is, this is how you do it, these are the updates, is really challenging where I am. And so I make sure that I actually show each provider at least once where it's located, and they all have my cell, obviously. But to really remind them, like, hey, if your kid is coming in just for an eating disorder, they can still be sexually active. That's an opportunity. And so really trying to hit home the fact that our mission for where we are is X, Y, and Z. In our case, comprehensive, holistic adolescent health. And so tying it back to the mission and vision of your organization, in addition to having some visible reminders in clinics or in your clinical spaces, might be a suggestion that I recommend.
I have another question. I don't mean to dominate, but how are the different clinics? You talked about different settings. One was academic primarily, and one was like a community. One was privately funded. And so, just to address the same issue that I brought up before, we started thinking about, okay, well, since it's a pilot and it's short, maybe from the get-go, we would get our people, like the research people, in and do kind of like a consenting type of relationship rather than an immediate incorporation, until people can kind of slowly adapt into their system. So I guess all three of you, if you can share some insight on how does your research setting operate differently from the private setting, and how does that promote success? I mean, your prep work.
So I guess I'll go first. For me, so both of ours are academic settings, but like you said, one of them definitely has a research component. I can't use the HIV clinic to provide those additional services that we need as far as like social work, case management, because that's not the grant is very specific to people living with HIV versus prevention as far as our clinical space. But what I have been able to leverage is the HIV clinic's research staff to help with the research in the general clinic in unique ways. And it's really kind of making sure that I sit down and talk to the administrative director and the clinical director to understand what the people that are employed by their grant can and can't do, or what would be in violation, and working out strategies in a team setting. The other thing I would say is, I'll use Letitia's as an example. Letitia's working through that HIV clinic, so she's technically partnered with the HIV clinic, and then the data that she's collecting is coming from that adolescent clinic. And as one of the few people that works in both, I'm the bridge, and so having a partner that might be able to bridge those two settings is key, because what I do is I quarterly go out and get the information from my general clinic, my adolescent clinic colleagues, and deliver it to the family clinic or the HIV clinic person, who then delivers it to Letitia's team, if that makes sense.
So I don't have like answers, but I think my perspective is, so I joined the faculty here at UAB. So I came to Alabama as a physician scientist in 2019. And before that, I worked in Massachusetts. And most of my research is based in healthcare systems in Uganda and South Africa. And what I would say is that the difference between like an outpatient clinic in Massachusetts and an outpatient clinic, academic medical center clinic in Alabama is as different as a outpatient academic medical center clinic in Massachusetts versus a community health setting in rural South Africa, which is as different than a rural clinic that is not academic in Alabama. And so I think just what I've like been humbled by is just how much you don't know about a setting where you don't work, and how you need champions in wherever you're trying to do what you're trying to do to help you understand the context. You know, this is like, of course, but it just, I'm like perpetually humbled by how much I don't, I think people maybe who are like have a PhD training might think that like MDs who do clinical work, like can understand clinical work happening in different settings, but we really like, I don't know, like maybe I'm just slow to learn, but like, I do not understand how other settings work unless I've worked there, and I can't work in all the settings where I want to do the stuff. So you just need to have like internal people who can help advocate, and you kind of, well, I don't know, it's hard because I think you need like the senior level people who are in charge of the administration, as well as like the people who are seeing patients every day. And that just takes time.
It does.
and unfortunately, I think it takes FaceTime, which has been really hard with COVID. It's really hard to like build those relationships over Zoom.
That's why I say I'm gonna have to become a traveling salesperson, so that they can have the FaceTime. So when they collect that information, because the whole idea is for those clinics to incorporate that practice as part of what they do and have it inform their medical decisions, right? And so if there's like 3 transfers of data, is it such that they get it right away, or is the research team the last to get the data, or is the research team collecting it and then sending it back to the clinic? Like, how do you interface with their EMR or provide the information?
No, these are great questions. And this is like the differences we were finding. So they collect their own data and they send the data to us. And we ask them, what can we do to make it easier to help with collection of data? So for some individuals, they said, we really need an Excel template where we can have really clear, identified data variables and how you want it to be laid out. And one of the clinics offered to make the Excel document for us. Like, I think that number one, we had champions at each one of these sites that valued the idea of sharing this data and understanding gaps. But they also, in these calls that we had, really were honest and vocal, saying, we don't even have electronic medical records. So someone shared how you could access REDCap and get REDCap available at your site to do data entry, data collection. So it was all of those things. And those are all now becoming the implementation strategies that we're saying we need to define and offer, make publicly available so people can do it at multiple sites.
Thank you.
Yeah, Robin, I'll let you speak in a second. It's hard. I know, like, for what Letitia's team is asking, I constantly sit with Dana, who's our data management specialist. And she's like, they need this. And I'm like, we don't collect that, right? Because in that particular clinic, everybody's under 21. We just don't collect that data. And they wouldn't know that. They, being the clients, wouldn't know that data. And so, Letitia's team has learned to be really flexible on, I assume, what their major outcomes are that they want versus what it'd be nice to have. Thanks, Lynn. Go ahead.
Yes,
Robin.
I was going to thank everyone so much for your participation, to our speakers and to everyone's active participation. I can see we need to have a round 2 with our group here and welcome that opportunity. So thank you, thank you, thank you.